Let's talk about shoulder dystocia. Background. Shoulder dystocia occurs when the descent of anterior shoulder is obstructed by the symphysis pubis. Impact of posterior shoulder on the maternal sacral promontory. Increased resistance between the fetus and the vaginal wall. Large fetal chest relative to the bipyramidal diameter. Truncal rotation does not occur during precipitous labor. It's diagnosed when there's failure to deliver the fetal shoulder with gentle downward traction of the fetal head, requiring additional OB maneuver to affect delivery, up to 3% of deliveries. Maternal complication, postpartum hemorrhage, 10%, fourth degree laceration, 4% maternal symphysial separation, lateral femoral cutaneous neuropathy, neonatal complications, 5% neonatal injury rate, with brachial plexus injury up to 20% of shoulder dystocias. Erb's palsy is the most common. Injury to C5, 6, and 7. Klumpke's palsy C8 to T1. Fracture of the clavicle and humerus. Apoxemic ischemia encephalopathy, usually associated with use of 5 maneuvers or more, and delivery time of 10 minutes. Clinical consideration and recommendation. Shoulder dystocia prediction. More than half of shoulder dystocia is less than 4,000 grams. 80% are not diabetic. Excessive weight gain, operative deliveries, multi-parity, epidural use, precipitous and prolonged second stage, prior shoulder, labor abnormalities do not predict shoulder dystocia. So excessive weight gain, operative delivery, multi-parity, epidural, recurrent shoulder dystocia, 15% recurrence rate. Universal elective C-section is not recommended. We should consider about current fetal weight, gestational age, maternal glucose intolerance, severity of prior neonatal injury, and patient preference. Labor induction. Induction of labor for suspected fetal macrosomia reduced risk of shoulder dystocia by relative risk 0.6. Any type of fracture 0.2. No difference in C-section or operative delivery, and no difference in brachial plexus injury. At this time, ACOG continues to discourage induction of labor solely for suspected macrosomia at any gestational age. Planned C-section, elective C-section should be considered for women without diabetes and 5,000 gram fetus estimated gestational age. For women with diabetes and fetal estimated weight of 4,500 grams, brachial plexus injury. Half of brachial plexus injury is associated with uncomplicated vaginal deliveries. Management of shoulder dystocia. Axial traction should be employed in alignment with fetal cervical thoracic spine and downward component with a vector of 30 degrees below the horizontal plane. Lateral traction lead to more brachial plexus injury and clavicle fracture. Routine use of episiotomy is not recommended. So the maneuvers, one is McRoberts cephalad rotation of McRoberts lead to cephalad rotation of symphysis pubis and flattening of the lumbar lordosis. Second maneuver, suprapubic pressure downward and lateral towards the fetal face and sternum. Number 3 is delivery of the posterior arm. These 3 maneuvers, 95% of cases in 4 minutes will be relieved by these 3 maneuvers. Rotational maneuvers, number 4 is Rubens. Hand is on the back surface of the posterior shoulder. Rotate anteriorly towards the fetal face. Wood screw pressure on the anterior clavicle of the posterior shoulder. Turns the fetus until the anterior shoulder emerges from behind the maternal pubis symphysis. Posterior, number 6, posterior axilla sling traction with 12 or 14 French soft catheter threaded to create a sling around the posterior shoulder. Number 7, Gaskin all fours maneuver and delivery of the posterior shoulder. Number 8, intentional fracture of the fetal clavicle to decrease the biachromic diameter. Number 9, Zanvanelli maneuver, cephalic replacement followed by C-section. Number 10, abdominal rescue, laparotomy and hysterotomy, and manual dislodging of the anterior shoulder from above.